It's fine.
Hey Dave, how are you doing?
Oh, hi. Can you, sorry, I'm just opening my window. Can you see me all right?
I cannot see you, but I can hear you.
Okay, 1 second. Let me just enable a video.
Dave, I'm gonna be right back in 5 minutes, okay? Hey, how you doing, Dave? Now I can see you. Hello? Now I can hear you, Dave. Can you hear me, Dave? I can't hear you.
Right. Okay. We should be able to hear each other now.
Okay, now you can. Now I can hear you and see you.
Good. Good. Lovely. How are you?
Good, good. And thank you, by the way, for presenting.
No, you're most welcome. Thank you for asking me. It's nice to gauge where people are at, and especially doing it transatlantically. It's going to be interesting to get the perspective of everyone in terms of what they're doing for LIMP and everything else.
Yeah, and one of the reasons why I was like hesitant is because live, because I think people are going to be interested in sort of like overall how you guys handle focus over there. And,
definitely, yeah.
So that's why I figured a lot of people probably interrupt you or stuff like that.
Yeah, so that's fine, no problem.
Yeah, and usually I was going to tell you that we start around like 1:05, so people start logging in at around 1 p.m. And then we give them an extra 5 minutes until most people are settled in, and then we sort of start from there.
Yeah, that's no problem at all. Yeah.
But great. So yeah, but the audio quality is completely fine, and so we should be good.
Okay, excellent. I'll share my screen. I think it worked before, but I'll just double check.
Yeah, when I had to step away. When I came back, I did see it. So
lovely. Okay, yeah, I won't do it now because it slows it down a bit, but I shall do it after. Great. Okay. I was going to ask the group, Henry, at the start, and just in terms of specific to limping children, is POCUS something that most people use a lot? What's your perspective on that?
I think we use it. Whether or not we use it a lot is, I think that'd be a good question for everyone. I'm actually doing a study on basically the ultrasound done by 10 people for the accuracy for paper fusion compared to radiological ultrasound.
Okay.
Yeah. So like I think there's one study at a Boston Children's in that. But it was a small, like it was not like a big number of participants, so that's why we decided to do a bigger one. We were hoping to get around 200 to 300 patients involved, but then COVID happened, so then our enrollment decreased dramatically. So
right, okay,
we increase our numbers again and sort of go from there.
Okay, grand, yeah.
But that's definitely a question that you can ask the group once we all log in.
Yes, yeah. Because one thing that I always like these Thursday evenings. It's so funny. Obviously, it's evening for me at 1 o'clock for you guys. I've just got home from work, hence the scrubs. So just, but yeah, I find it really interesting how much abdominal stuff you guys do.
Yeah, I mean, as you're aware, like the focus is like taking off. Like here, I think it depends on varying like comfort levels, but I think it's a hot area of interest, especially for like research. That we're seeing more and more research going on for more and more applications, so it's become more uncomfortable. And the adult guys lead the way more than the kids guys. They're sort of like ones that are leading, and then they sort of like kind of trail behind in terms of what they've done, or just affirming their findings that we are as competent to do some focus studies.
Yeah. Yeah, no, agreed. Well, I've just done a nice one just a couple of hours ago before I came home. I use the ultrasound as a sort of fluoroscopic, C-arm for manipulations and reductions. Oh, hi.
Yeah.
Can see that. So we just did quite a nice one just at sort of 4 o'clock there, for quite a mangled mid shaft radial and ulnar fracture. And we don't have a C-arm or anything, but I just run the machine over it and check sort of reduction in terms of angulation. It works quite well. The orthopedic team like that quite a lot.
Yes. So I don't do as much as like for the MSK as much as I would like to, but because X-ray and our orthopedics are so fast here, but there is, as you probably aware, like some evidence of like usage of the ultrasound for like broken forearms, but I personally don't do them as much. But there's a lot of people that do it more than me. I'm more like the abdomen and sort of like head and neck. That's where obviously cardiac and fast, but that's where like sort of my more specialty comes in. Because here, as another, like there's actually a subspecialty among focus people. So there's like people that are like like strictly abdomen that they're more comfortable with. So, things. That's why I like doing this on Thursdays, because you'll see perspective from everywhere.
Yes.
Depending on the night, we have some people from Israel also joining in.
Oh, brilliant.
Yeah, so next week, actually, I think in 2 weeks, we have Eric Shire, who is from Israel, who's going to be presenting again, because he presented like I think 8 months ago, and he wanted to present again. So we have people from all over. So.
Cool, good. One of the papers that I'm going to allude to is quite a new paper that was conducted in Haifa in Israel in relation to a clinical decision rule for limp, but it just came out in JAMA like 2 months ago. I don't know if I'm going to allude to it. Yeah, so it's quite interesting because that's very similar to what we do. They sort of beat me to doing a study. Had about 600 people, so that's good. Yeah.
Yeah. So actually, that one of the things I was thinking about is that the study I'm doing is kind of similar to them, although they just went for transsynovitis, but I'm just going for hip fusion. So, but it's going to be very similar. So we're kind of like
great.
Probably modify kind of things just because it was a huge study. There's retrospective though.
Yes, exactly.
We're doing more perspective for ours. So I think there's enough difference for us to continue on. But it was a very good study.
Good. Yeah. Good. Yeah. Are you going to monitor the chat, Henry, during it? So you're just going to keep an eye? Okay.
Yep.
Just feel free to jump in.
Yeah. Sometimes I'll interrupt because, or sometimes I just comment that they make. You'll find out once you review, because sometimes they just makes comments about it, and then sometimes there are questions, and then I'll try to interrupt you as less as I possibly can.
Yeah, no problem. That's fine. Are you on the shop floor there? It looks like there's a lot of nurses and things going around. Is that right?
Yeah. Yeah. So it's a very hectic day. I didn't think it was supposed to be, but now it's hectic. So.
Okay. So might you get called away?
Unlikely. So it's coming to some downside, and because I try not to do this, but sometimes I have to work when I do this.
Okay.
I can't request to have every basic off, unfortunately. So
yeah, that's fine.
Every now and then I do have to work. So, but yeah.
Okay, doke. Cool. I'm just going to nip over to the toilet, and then I'm ready when you are after that. Okay.
Okay. All right. Thanks. Dave, is actually a study done by Matt, who's actually on the call right now.
Okay.
So I don't know if Matt is still it's on right now. You can ask him or just travel online. So he used just the our list to sort of try to get more people. But
Okay.
Matt is right there, so he actually can ask him about it.
Yes, absolutely. We want as many people as we can who meet that criteria.
Okay.
The goal is to get as broad as possible. We've got a couple of like 1 or 2 contacts sort of on the European front trying to spread to some of the listservs over there as well.
Okay, no problem.
Did you get the survey link?
No, I just got the initial email. It didn't appear to have the content, but I may not have checked through everything properly.
The one that came through Henry's list would have been just sort of like an ad to have people emailed if they were interested.
That was what I got, yeah.
Have you emailed that? I'm trying to, oh wait, actually. Let's see. Are you on the P2 like list in general, like the big one?
Yes, yes.
The intro invite email went out to that Monday morning at 6 a.m. East Coast US time. I found that a number of people, it's gone into junk folders, unfortunately.
Okay, no, I received the initial one, but I didn't reply to anything.
Okay, you don't need if it's the one that's longer, the actual link is in blue on the bottom of the email, the one that went out Monday morning.
Okay, I'll have a look, yeah.
And I think it went to your Gmail. Actually, yeah, I don't know if we actually had you on that email or not. But if you just respond to with whatever email you want it sent to that P2 network Gmail account, then I'll send it out to you.
Okay, no problem.
And Dave, like I said, we'll give everyone till 1:05, and then I'll introduce him and then start the chat.
Yeah, no problem at all.
Matt, I'm sorry about the hijacking this conversation for 30 seconds.
Go for it.
Matt, I was confused. There were I was forwarded two different, maybe the same survey, but one was titled International PM, and I was confused. So sorry about the confusion.
We sent a little more fuller infoed email specifically to those who are on the active P2 network list, which is like 330 individual emails. And then we sent a truncated, the one I sent via the PEPEC list is sort of a truncated kind of let us know if you're interested and haven't heard otherwise. It's the same thing. So the one that says like, there's on the bottom of a longer email, there's the actual email or the survey link. That should be the one to do. And the intention is sort of research ideas as broadly as one can think of.
So Matt, on the P2 newsletter, the link is to email p2network.research@gmail, and then the survey gets sent out.
So if you're on the P2 listserv, you should have gotten the email at like 6 a.m. East Coast time Monday morning that would have the actual link in it. But to cover our base, if anybody didn't get it, we put it there. And then we're otherwise sending like effectively what the bit that went in the P2 listserv, like memo and the routine mailing is basically kind of the more generic ad that we're sending out to broader like SCUF and Peruki and all the other like take your pick on potential ultrasound networks or PIM networks to try to be as broad as we can. But we figured the P2 group itself was going to be a pretty high yield as far as bodies who would meet the inclusion criteria.
All right, so it's 1:05, so we'll get started. So today we have Dave actually joining us all the way from the United Kingdom, which is at nighttime for them. So I do appreciate you presenting for all of us. So we're very excited to hear what you have to say. So you can take it away.
No problem. Yeah, good evening, everyone. Not quite nighttime, but 6 p.m. UK time. So good afternoon to you guys. I'm just going to share my screen and let me know if you can see it all right. Let's do it from the beginning, one moment. Okay, can you guys see that all right?
Yep, you're good.
Okie dokie. So yeah, I'm a PEM consultant in the extreme north of England. I live in a place called Newcastle, you may have heard of, and I work in a place called Sunderland. If anyone's seen the film Billy Elliot, my accent resembles that very closely because that was filmed about a mile from where we live. So that might be the only thing I can kind of get your imaginations with in terms of that. But if you've had a chance to visit England, it's other than being a bit cold, it's a great place to come to. This is our emergency department. As you can see, the sun always shines. And yeah, I was grateful to Henry asking me to share some of our practices in terms of what we're doing with POCUS here. I'm just waiting for the slide to move along a bit. It's just slowed up, and then there's a slide explaining our POCUS faculty. There we go. Sorry, just a little bit slow. Sorry, and do chip in if you can't understand or if you'd like me to slow down or anything. So we have sort of 6 consultants, really, senior doctors, I guess what you guys call attending physicians, who are from either the pediatric emergency medicine side or from the adult side, who do some specialty training in PEM, who are, I guess, less pediatric than me and my colleague Niall, who also sits on the board of Peruki, who someone mentioned earlier. We've then got some junior doctors who are very keen and are doing training in POCUS as well. So these are the kinds of things that we utilize POCUS for. I'm sure it's very similar to the things you do in your own department. It'd be interesting to get an indication of who does, POCUS for hip effusion for children with limp or anything else similar, probably by way of just putting it into the chat, and we can pick that up either at the end or during. But yeah, it's certainly probably one of the commonest reasons we utilize POCUS almost day to day. Well, certainly day to day, actually. So I'll start with a clinical case that occurred just back in December. I was on a weekend shift, and we commenced the shift in the afternoon, but a couple of members of the team had seen a young lad just turned 1 year old who really just came in with non-specific symptoms and presentation, being a bit unsettled, reduced oral intake, who had a very unremarkable history, who was developing normally, but had was sort of just at about the point beginning to walk or cruise around, holding onto furniture independently. He had no regular medicines and was fully immunized. So when one of the members of the team reviewed him, he was certainly nice and settled. He was afebrile, but it appeared sort of almost within the time he'd been in the department, or certainly the last 2 to 3 hours, he was sort of stood in his mother's lap with kind of the right leg off the floor. There hadn't been any story of reduced activity at home or of limp specifically. So the team assessed him and felt that he appeared to have sort of features of an upper respiratory tract illness, but actually that they were unable to make any kind of clue about what may have been going on at the right lower limb. So he got a bit of a legogram. I guess it's the kind of thing we probably want to avoid happening, being the senior presence on the shop floor, but it's sometimes what happens to trainees who are new in PEM or in pediatrics, where, ultimately, I guess here they were looking for trauma potentially as a concomitant issue. I guess you wouldn't want to miss a femoral shaft fracture or injury, and I guess probably thinking about potentially non-accidental injury as well in such a fairly youngish boy. So they weren't really sure as to whether this was hip in origin or knee in origin, and the symptoms were very short-lived. I came on and I grabbed the machine and I had a look at his hips, and I'd been doing this probably only for a few months by this stage, and was certainly the only person in my sort of hospital really who was looking at hips, and these images were taken across from our machine, so that, sorry if they've not came out as well as some of the other pictures I have. But this is for anyone who, I can talk through it on the following slides in terms of image acquisition, but to those who do hip scanning, you'll recognize that this shows certainly a difference between left hip on the left as we're seeing it, and then right on the other side. Oh. Sorry, if someone was speaking, I missed what that was. If someone was asking a question.
Go ahead. I think it was just an interruption.
Okay, sorry.
Yeah, thanks. Yeah.
Okay, so we're clearly seeing. I'm just going to grab the pointer here. We're just clearly seeing a significant effusion distending the hip capsule on the right side. So I think that was, even at that stage, that was a bit of a win for me, given that this child came in very undifferentiated, without really true signs of limp, but just some odd behaviours. Was afebrile, didn't look in any way toxic, and had already been subjected to unnecessary radiation. So a few things were sort of, I guess, troubling me with this lad, although he looked very well. And I thought he agreed he had a concomitant upper respiratory tract infection. He seemed a bit on the young side, I guess, for some of the transient synovitis that we see sort of regularly. Clearly, it's in a sort of walking, limping age where they're walking, where they're going to demonstrate a slow, indolent kind of limp. So I couldn't be certain clearly from the appearances on ultrasound that this wasn't potentially a septic arthritis. So I undertook some blood tests on him. Just waiting for the screen to move across. Okay, it's doing it eventually. So yeah, so he had a normal white cell count and no evidence of any rise in neutrophils, but he had a fairly elevated CRP. Presume you guys use CRP? I can't be totally sure that I'm sure that you guys do as a first line inflammatory marker, but
Yeah, we do.
awesome. Okay, so we try to do ESRs as well. Clearly, we have an issue with our lab processing ESRs, and I wonder whether that's the same everywhere. Obviously, it's measured through the the movement of an erythrocyte through the lab, but they have to be the most specifically filled and not overfilled, not underfilled sample. So we never really get an ESR back. But we got a CRP on this boy, and clearly, I suppose from how well this lad looked, I was a little bit surprised by how elevated his CRP was. So I asked the orthopedic team to come and have a little look at this lad. He's still examined really quite well. I was fairly confident that I could extrapolate my findings to just his hip when I looked at him, and I showed the orthopedic doc the pictures, and you can imagine the response we get. And we use a lot of POCUS for fractures and for manipulation of joints and fractures. And I was telling Henry, I just did one a couple of hours ago before I finished. And you can imagine their face when you tell them that you're going to get the ultrasound machine and have a listen for a fracture. It's I don't really say that, but it's clearly they are not on board unless they've got x-rays to sort of extrapolate findings from. So she said, clearly, yeah, I agree, that's an effusion, but what do we do with that? Can you tell me, is that, does that suggest septic arthritis? Is this within the remit potentially of transient synovitis? So we hung on to the child. Clearly, we admitted him. We actually held off with antibiotics that evening, and the consultant team reviewed the following day. And basically, the child didn't spike a temperature at all. He remained quite well, but his hip sort of became a bit more like what a septic joint is like, almost a fixed flexion, certainly more painful. So he went to theatre for an arthrotomy and a washout, and there was a moderate amount of pus there. The child eventually grew strep pneumoniae, so clearly my thinking being that was related to his upper respiratory tract infection. So he got 5 days of IV antibiotics. He got home on Christmas, and I remember I was at home, but I was checking back on the hospital system to check that the little guy got home before Christmas, and he did just in time. And then he completed a prolonged course of orals. So I guess using COCUS criteria, this trial was fairly interesting in that, would we call him non-weight bearing? Yeah, I'll give him a tick for that. He's, like I say, he was sort of just about at this cruising or standing phase anyway. But he wasn't, I guess, by non-weight bearing, when I think of my children with potentially transient synovitis, I'm thinking about the ones who have a relatively normalish examination. This child, I guess, by the end certainly didn't have that. He had elevated inflammatory markers, in this case a CRP, but he was afebrile throughout, and that was from about 36 hours of being in hospital, and he also had normal white count. So we know that the work done by Cocker's team was sort of about the positive about the ability to predict septic arthritis, done quite a while ago now. And classically, this work has been shown to be difficult to validate internally, in terms of, much as the case in research, to validate outside of the sort of, I guess, institution where it was conducted. But clearly, I'm sure we all use this when we're thinking about a child who we're reviewing. So I'll talk a little bit, we'll come back to the case a little bit at the end, but talk a bit more through sort of hip scanning and what we do and why we think it adds a bit of benefit. This is our machine that we have. It's the GE Logic, and it's I don't know if anyone has this machine or a similar one, but it's a bit like a sort of point of care plus kind of machine. It's what we lose in user friendliness. I think we gain in some functionality and gain in kind of good images. We have it's a 12 megahertz high frequency probe, and that's clearly what we'd use for this kind of MSK scanning, a rep from Sonosite showed me one of the brand new Sonosites recently. She came to visit our department, and there was a 19 megahertz, a 20 megahertz probe that gave incredible images. And she started the kind of meeting by getting the probe and smashing it onto the floor in front of me, in front of my eyes, which is really quite interesting. Apparently it's a shockproof probe. So she got my attention, certainly. I thought it was quite good. So the technique that we use, obviously, is we use a high frequency probe, child covered appropriately, unusual explanations that the ultrasound machine isn't scary, isn't going to cause any harm, demonstrating the feel of the gel on the back of the hand or somewhere else, back of our hand. And really, we're just scanning either in short section or long section, at sort of proximal femur, depth kind of appropriate. Often the depth you require for these kids is no more than 4 or 5 centimeters. It's probably fairly surprising. Being in long axis to the femoral shaft, and then rotating obliquely for when we're beginning to scan for where the femoral neck is. On the other slide, it just shows some of the planes here that we can assess. We're mainly assessing the anterior compartment, and we're aligned, I guess, overlying generally the green line there on the diagram. I think it's really important to be aware of anisotropy, and that's something I'm going to come and talk to you guys at the end about. But I think just very slowly and very carefully is important. We like to save cine loops of particularly if there's any obvious findings, just so that kind of anisotropy of a rapid picture acquisition can be avoided. You can reproduce that if you think you're getting darker hypoechoic structures. Can we be certain that's fluid or not? I just took a photograph of the anatomical skeleton in our department just to highlight about this anterior compartment. So I guess when I first started doing the scanning, I hadn't really appreciated that this was such a shallow, almost fossa. It's really kind of, not deep at all, as you will see from some of the ultrasound images that I'm about to show. You almost assume that you're going to get, I don't know, is my mouse showing on the screen, guys?
Yes.
Thanks, okay. So, when you're looking at sort of Shenton's line, you're looking at the sort of joint itself going into the acetabulum, I almost expected that I'd be getting a real sort of sharp, acute kind of bend here when I was doing my scans, but really we're not sort of assessing in the almost, lateral to medial plane. We're literally coming anterior posterior from superficial down to deep top of bed to bottom. And this is really quite a shallow little fossa, but this is sort of the area in terms of anatomy where we're going to end up. So I've got some ultrasound images that'll hopefully take us through this in a lot more detail. I don't know if for anyone who does hip scanning, if they're brave enough to admit that, and this might be as a result of different kind of med school, US versus UK, I kind of had to remind myself exactly where the capsule sat and where it didn't, if I'm being totally honest with you, and where I would and wouldn't expect that fluid to accumulate, because having done loads of these scans now, sort of, kind of close to 100 now, it clearly can look a little bit different every time, and I just had to remind myself anatomically whereabouts that capsule extends to and where it doesn't. And we can see where we expect the synovium to be produced. It's of relevance to, it's a particular relevance because more superiorly, more proximally, relative to the femur laid on the bed, there's always an area of sort of anechoic, hyperechoic area, and that represents just that normal capsule. But we'll see on the following sonographic images when it's positive, where it distends to. Oops, sorry. Okay. I guess, yeah, on the left shows the position we'd be at. Really just sort of oblique, but again, that angle itself will vary from patient to patient based on size and anatomy. But what we're trying to image is obviously the femoral head, the superior aspect of the femoral head, and then either the physis, or if we're talking about a child who's older and ossified, or fused joint space, sorry, with a fully ossified femoral head. It'll look a bit more like the image here, with obviously the iliopsoas muscle sat on top, layers of fascia beneath, and then the capsule, which often looks a sort of different color to the muscle, as sort of a thicker kind of gray pattern. So that would be kind of normal, I guess, there. All we see is just this thin, tiny thin slithers, not even 0.5 millimeter, that's present on the normal side. This, I guess, is a really nice image, not mine, shamelessly stolen, but probably, again, one of these sort of high frequency 20 megahertz probes. So this is the kind of appearances that we're looking for. We're seeing the epiphysis, we're seeing where the physis would be. Again, usually in a much younger child, this is a big sort of gap, and much sort of more of a space there. And then really just for the most anechoic or hypoechoic material that you can see on your scan. I always talk to the juniors about, that when we're seeing muscle, we're seeing blood, presumably, within the muscle that looks darkest, but the darkest thing you're going to get is this rim of fluid that you see. And I would say from this image, there certainly looks to be thickening of the capsule itself, which is one of the other signs we think about, which I'm going to talk to you guys about. So this would be a positive scan. So there's different ways to assess for an effusion. We can either look at the bony cortex upwardly and measure from that point. Keep losing my mouse. And measure the distance from here to the more sort of anterior aspect of the capsule. Or you can just measure the sort of distance in between, and different things have exist within the literature. I guess here we're looking at sort of, if this was unaffected side versus affected side, you're looking for that difference. We're utilizing POCUS here very much in its intended purpose, almost binary, looking for differences as an extension of our clinical examination. For my colleagues who, I guess, are the POCUS non-believers in our department, I'm sure every department from you guys has them, who just haven't undertook training to learn POCUS and are probably at a point in their career where they're not likely to pick it up. We just sort of, they might ask, well, okay, what is it you're showing? What is it? And I would kind of ask, well, what is you're examining? What is it that you're looking for when you examine? You're looking for restricted range of motion in a child, giving a slight little wince of the face, sometimes nothing, not even that, to assess for pain on, say, external or internal rotation. Well, really, this shows us what we're looking for when we examine. And POCUS can identify quite small effusions, as I've stated there. Here are just some high frequency probe findings compared with how it looks on MR. Again, with the adherence of this capsule just sat above, this almost normal appearance of the kind of what looks hypoanechoic almost at the top, with just a tiny thin sliver of nothing else. And clearly the capsule is almost contiguous, isn't it, with that bony layer, so certainly not being distended. So in the literature, it'll talk about that being convex is abnormal. I would certainly agree with that. It's not exclusively the case, but certainly that tends to exist when you have a positive effusion. And that we're looking for differences of over 2 millimeters comparing affected to unaffected side. I think what we obviously all know from transient synovitis and from innocent effusions is that they're going to present at varying times. So some will have been to their family care practitioners or to walk-in centres before coming to PZD. They may have had, 48, 72 hours of symptoms, and things can either be at their maximal or they may be settling down by that stage. If we were following children up and we're re-reviewing them who've had anti-inflammatories and have had medication and have had a lot of period of rest, we know that clearly their effusion size is going to be a lot smaller than someone presenting immediately that day at the height of their symptoms. And I think that's what we've demonstrated with scans. So I probably wouldn't be too fixed about a definite size in terms of 2, 3, 4, 5 millimeters. I've got a range from the work we've been doing about the size of effusions we found, but I think clearly you're looking for a difference, and you're looking for that confirmation along with clinical suspicion, and along with thickening of the capsule and convexity of that kind of capsular space, that's what you're looking for. It'd be nice to talk to the guys at the end about your experience of this. This has been a real winner and a real game changer for us in PZD, because you kind of put the probe on you and you always get the answer that you expect. You always see either affected side, or you see, you know, kind of resolution when you expect it to be quite mildly symptoms who presented late. If you see big effusion and you're worried about other features that suggest intra-articular infection and or early osteomyelitis, we tend to get those features that we expect. In other words, big effusions when we expect them, and always something that you can pick up on, based, you know, compared left to right, even if the child examines quite normally. And that's I think the beauty of point of care. So again, this is one of my images that's kind of a bit more grainy, as you can see. And again, clearly on the right side of the screen, left hip, affected side, significant effusion size, 0.9 from bony cortex to capsule, bit less from capsule size, and again, kind of continuous with that normal part of the upper capsule. What was I going to say there? Something of note. Oh yes, I'm always telling the juniors when they're saving the scans, you know what it's like when you're going through and you're kind of rapidly saving. I would angle the probe with my probe marker medially towards the groin for one side of the hip, and then flip my probe the other way so that the probe marker is pointing outside laterally on the other. So that, in other words, when you do left hip, left hip, left hip, left hip, and then you swap and do right, right, right. If you're looking at a subtle change in a child, you're looking at a tiny little, you know, 1.7 millimeter difference between the two or something, you might confuse the sides when you're reading them back on the machine, and that's if you're not labeling them there and then. I probably am a bit naughty. I do a bit of my labeling when I've finished with the child, you know, they're dressed, and I think it's probably the kind of way to do it, I guess, in pediatrics. So you can sometimes get confused. So if you flip your probe from one side to the other, you know, okay, those first 7 images are the left, and compare them to the right because the hip is facing the other way. Does that make sense to everybody? Hopefully I'm not talking rubbish. Great. And have a drink.
I had a quick question, Dave. For the ones that you think are septic, do you guys do your own tabs, or does the orthopedic doctor do the aspiration tabs?
Yeah, so to be honest, we're just at the point of getting ortho buy-in for that. I've got a very keen pediatric orthopod who is very keen that we can do that, but at the moment, no, it would be them. And to be honest, for our kids in our department, it would tend to be theatre for that and a full arthrotomy. I guess this is the bit where I think it's going to really take effect. If we can influence directly what we do in terms of, you know, obtaining an aspirate and withholding or starting antibiotics, I guess we could go there. We can even look under the microscope there and then for organisms as opposed to waiting for culture. But no, I think probably where it's mainly made a bigger impact so far is in relation to transient synovitis. And we're just really looking at, and this is the sort of last part of the talk actually that I'm going to come on to now, Henry, how it really does play a role in terms of suspected septic joint. That makes sense.
Okay, all right, thanks.
So we know that X-ray signs can generally speaking lag behind, and that is true clearly for something like Perthes, where studies have shown that I think sort of highest I read was 55% can present with effusion, and we know that ultrasound is is the gold standard for identifying effusion. We know that the reason I first got into all of this is I started scanning hips, and then I spoke to some of our sonographers, and I spoke to our radiologists who do MRI, and really they seemed, I asked them about kind of, some of the things they're looking for in scan, and it seemed as though they were just doing a very, very binary, quick 1 or 2 image. If anything, we almost seemed to were spending more time and saving more, stricter kind of images in different planes, looking in the, not just in the long axis, but in the transverse and measuring. And we seem to be doing more than they were. They said, look, at the end of the day, if ortho asked us to do a scan, we just say fluid or not. And that really shocked me. That really surprised me. And then in relation to the MR, it seemed as though they were, again, far less keen of being able to definitely identify yes, you can identify a bit of fat stranding and a bit of effusion, but really they were doing that to rule out bone marrow edema more for osteomyelitis. So I thought if this is something we can really, really master, we can, we're not going to need to involve them whatsoever. So I think we know it's the gold standard for fluid. We know we can keep it quite binary. And there was a study by Vieira and Levy here at the bottom, last 10 years or so, that looked at training up emergency medicine practitioners, I believe, or practice nurses to do scanning. And in the highest rated...
What do you
Sorry?
have now?
Sorry, go. Did you want to say? Did you want to ask?
I think she just wasn't on mute.
Okay, no problem. In the group of people who were trained to do hip focus, those who were self-rated as the most confident were achieving really very, very high sensitivities and specificities for performance for their scans. And even in the group who felt less confident at the end, there were still sensitivities of upwards of sort of 84, 83%. So we know it sort of performs well and is easily teachable. I guess this is the part we were talking about, the kind of crook of it all. So we can identify effusion, but there's nothing at this point in time really that we can reliably say rules out septic joint based on appearance. We were looking into size of effusion based on the kids in our database, and while of course those who have more established problems and we expect to have restricted range of motion in the hip and bigger effusions, whilst they do have them, when you expect it, the converse can be true, whereby kids who've sort of, a bit like my child, who didn't really do a great deal, didn't have a massively sizable effusion, didn't really spike temperatures, we could easily image what we think is a simple transient synovitis, and it, we can't be certain that it isn't septic joint. So I guess that's where use of sampling in arthrocentesis comes in. Perthes has been an interesting one for me because I've had probably about 3 or 4 suspected Perthes, but only one has gone on to get confirmed on MR down the line, who that clearly had an effusion. And again, there's not a huge amount in the literature in terms of backing up whether or not that's an initial test, reasonable measure in terms of finding effusion and then following that up. I'd looked into use of power Doppler, and I think I put this to the group when I was first introduced to this group, probably about a year ago or a bit less. Is anyone using power Doppler to look at hyperemia and to look at increased vascularity, etc.? And again, there's not a great deal out there. I wondered, this is the image of my child from the start with the septic joint, and obviously you just wonder about kind of more echogenic material here. Clearly it's not as as anechoic as you might expect. And does that help you with thinking about kind of more like pus in the joint as opposed to just clear fluid? So I think probably a bit more kind of academic work needs to go into that to be absolutely certain. But the more we're doing in this, the more we're understanding. There were some concerns with false negatives in terms of misreads in certain studies. Misreading or misscanning can occur. I always encourage the team to sort of save cine loops, save plenty of images in different planes, and to fan through that joint capsule to ensure that there's no kind of concern from the point of view of an isotropy where we're seeing anechoic or hypoechoic appearances, and basically misscanning them really. So this was one image that was, I think, deemed to have been negative and then found to have been an inadequate view, and subsequently effusion was present. I think the biggest group that we would see for false negatives would be those who present early. A study that I'm going to mention to you guys at the end that was done in Israel in the last few months also found this, that those within symptoms of 24 hours essentially didn't have obvious effusion there. And clearly I think we have to manage that group of patients slightly more carefully in terms of what we tell parents. Talked a bit about anisotropy. I don't know if everyone's familiar with this in terms of doing MSK scanning. Our background to ultrasound here, mine and my colleague, was that we've completed a postgraduate degree, and we may take this further to a full master's, but we started by doing a sort of 6,000 word physics assignment and it were assessed on that for the start. So we got all this sort of stuff hammered into us. Clearly that would be a potential source of false positive signs if we're not sort of interrogating the tissue structures slowly and carefully. And this just is an example of patellar tendon. If you're looking at a fibular structure, we're sort of seeing the difference of appearances we can achieve through angle of interrogation or angle of incination. If that makes sense. I just re-included this little bit at the end just to talk about CRP, and that it's fairly well validated actually if you look at the studies in terms of its use. So CRP being elevated beyond 20 gives a really gave in this particular study a pretty excellent effect from an odds ratio perspective, and that if white count and CRP were both normal effectively, then your probability of septic joint in this study was 0. I think that's great and that's all well and good, but that's probably not the angle I'm necessarily coming at this from. I'm coming at this more from the angle that I'd like to reduce kids having unnecessary bloods really, and to make, you know, a quick visual clinical assessment which is more sensitive than just an examination alone in the group who clearly don't need bloods, you know, who don't need a great deal more and can be discharged maybe without follow-up for transient synovitis, and preventing blood tests for those who really shouldn't kind of get them in the first place. So in our department, we see about we're on about 32,000 kids a year now after sort of COVID and last few years it's increasing. We see there was a range of attendances for limping children between about sort of 70 and 120. It feels like a lot more actually, to be honest, because I guarantee I see almost one of these every single day and sometimes a few a day. But I think that averaged out to 0.4% of our attendances, and that actually is what would fit in some studies for attendances for limping kids in PEDS Europe-wide. Be interesting again to get the perspective of others on the chat to see how that compares. We've got, I think, around about 50 in our database now. I must admit there's a few I forget to have saved in there. These are all the ones with positive signs. There's 60% right hip, as studies often are, isn't it? It's never a clean split. 75% for naughty boys as opposed to girls, and again, classic. With a range of ages really, from our youngest being below 1 right up to I think 7 years and 6 months. Effusion sizes ranged, taking a baseline in terms of the maximal, they're around about sort of 3 millimeters, right up to, I think we've had I probably haven't updated this slide from when I last gave this talk, but even high, I think almost close to a centimeter, which is pretty decent for effusion, I think, in terms of the volume that you're going to get. It's probably getting them for sort of 5-6 mils. It's quite a lot to be in the joint space. As I said earlier, we've had one query Perthes with a negative subsequent MRI and one that they're not quite sure about. And out of that number, we've only had 2 confirmed septic joints with an organism. A bit about background about irritable hip or transient synovitis for those who I mean, everyone on here is clearly very familiar with it, but we know it's of an unknown etiology, often with a recent illness or a concomitant illness. I think my experience is that these kids typically don't have an obvious illness that we can think about. I know my child did have with a septic joint at the start, but in terms of transient synovitis, I think most commonly I don't get a story that they've got cough, cold, runny nose, ear infection. I'd be saying that's probably only 10-15%, to be honest, that there's obvious story. Definitely get a history of overuse or trauma, so kids who've been away on holiday or been doing new activities have then 2 to 3 days down the line ended up with this sort of obvious effusion, and I guess that makes obvious sense. It apparently affects around sort of 3% of the population of children, and we know that obviously pain persists related to the effusion and that can resolve over time. In terms of septic joints, we know that the classic organisms are the staphs, also the streps, or if you're in your examinations, Kingella kingae, which everyone remembers really well. This is this fastidious organism that is difficult to pick up in culture, and apparently is also more likely for you to not achieve an inflammatory marker rise with Kingella. And we know there's significant complications of a missed septic joint. I'm sure we've all met even these little babies of this age with this limb sort of, you know, held in an odd position that you can't really, that might look like nothing if you just glanced at it. But I remember I had a child a few years back where one of the doctors thought this child was having a tonic seizure because of the way the limb was held, and actually it was clear the rest of them, you know, was fine. It was actually a hip issue, but quite interesting how it can slip sort of through the net if you're not thinking about it. Well, like I said, previously some studies have shown that effusion can be present there, and I guess it's whether or not we would be able to take POCUS further, looking at that in terms of appearances of the femoral head. I haven't been trained to pick that up yet, and I don't know. I wouldn't feel confident definitely making a decision about that. That's something I might look to expand my practice just from an emergency medicine point of view, where I can kind of, you know, I'd refer on ultimately to the correct person, but whether I could give an opinion about whether or not this seems to have features of femoral head changes. And obviously you could look at vasculature using Doppler, but again, I don't do that. So last few slides, you'll be glad to know. So kind of why POCUS? Well, we could all give a really big list, couldn't we? That it's quick, it's reproducible, it's portable, it's, you know, it's safe. Parents seem to love seeing these images on screen when we're talking about, you know, irritable hip. Some of the parents have seen kind of my colleagues who don't do POCUS and then have been reviewed by me when I've re-scanned them, and I think they've been fairly like satisfied seeing that they're, oh, this is the effusion that we're talking about, and you can see it's reduced, or you know, it's looking kind of normal now. It just gives them that bit of reassurance, and often the child as well. POCUS for lymph, I think, is really important because we know that lymph's extremely it's non-specific in its presentation. It can represent a lot of different, often serious diagnoses. We've had children with clearly lots of knee problems, with abdominal concerns, spinal concerns, scrotal concerns, things like pyomyositis to the psoas muscles away from the capsule, all of which have presented as limp and have been missed, and the children have gone around the houses with either unnecessary surgical input or unnecessary bloods, I guess you could argue, unnecessary imaging. And I think clearly if you can see this effusion, you can identify the site. You can say, okay, we're dealing with the right hip, it's not the knee, this isn't NAI, this is a missed fracture, or, you know, we don't need to think about skeletal survey, we're looking at effusion of the hip, you know, and then we integrate that into our clinical decision rule as to whether or not we want to do more in terms of whether they need bloods or whether they don't. And I guess it's not to be understated that the sort of malignancies are really important to think about as well. We've had quite a few recently. We've had a bad run, as you often do, of diagnosing kids with sort of ALL at 10 p.m. at night in the PZD. Some of whom in my mind over the last couple of years have presented with limp. So if you can identify hip effusion, yes, we get limp with malignancy due to sort of hematopoietic mass effect and due to marrow hyperplasia, but you shouldn't get effusion. So if you see effusion, you know, they don't have cancer really there and then. You know, that's me being simplistic, but that's, you might even, you know, just reassure people a little bit that evening that you've got a focus for your problem, and that you can, you know, you don't need to ask the oncologist to see the child because you're worried. Clearly, if they're pale and they're looking concerning, then that's going to be a bit different. But I definitely think it adds something in that sense. So I just thought about how we might integrate this. Well, you know, we know that it can rule things in. We know that its sensitivity is fairly high. Its specificity is maybe a little bit lower. If we were to perform this based on some of the missed cases of, you know, lack of effusion based on when we scan, but I certainly think that if we do see a positive hip, a positive effusion, we confirm that site. We can exclude non-hip MSK causes, and if the child's afebrile and weight bearing, then that's almost certainly transient synovitis. Now we follow these children up in our emergency clinics. You know, does that mean that we could save a lot of attendances per year for these children? I'll be interested to know what you guys do for transient synovitis, whether or not you specifically offer them follow-up with, you know, following their anti-inflammatories, or whether you're just happy to safety net them and send them home. And then I guess you'd have to think about the younger group. So if we're looking at not weight bearing, what do we think about children who are doing some funny modified crawl, or those like my child who's just sort of had just recently stopped standing up? I think it's always important to think of the caveats of it. This was a recent paper from JAMA from June, conducted in Haifa in Israel, looking at exactly this. They had about 1,400 kids, I think, in total, of which 621 had been scanned. It was a retrospective study, mainly males again, and they looked at the clinical decision rule with these characteristics. Interesting how they included the final point about lack of features, basically of worrying in terms of malignancy, lack of significant lymphadenopathy, pallor, or hepatosplenomegaly. And this study performed pretty well in terms of looking at POCUS for correctly identifying transient synovitis. I'm sure we could reflect similar numbers conducted kind of in our setting as well. The specificity fell down based on, as I say, some of these early scans, and I think there were 5 or 6 in total that I guess affected that specificity, and they were scanned early and they didn't have any obvious effusion at that point. So yeah, questions I guess is sort of, how is this going to go forward? What can we definitely do? How can we convince our non-POCUS using colleagues that it's really a benefit and what it adds? You're clearly going to combine your clinical suspicions with your examination. But I mean, I'd be saying that, for example, if you were to compare a negative scan versus a negative set of blood tests conducted there and then, I would be most certainly in favour that the negative scan adds a lot more to that, given that you could, have a child with a normal white count and CRP at one moment, they then come in the following day, numbers are through the roof, and really you've falsely reassured them. I guess that's me being a bit simplistic again, but parents take things quite as read, I think, when you say them. And yes, we give them a really in-depth safety netting and explanation, but I think you can guarantee they're going to leave the department and say, okay, the bloods were all normal, everything's fine. They're going to then sort of stand down their concern about the child maybe a little bit less. If we can scan them and at that point say, okay, symptoms are significant and the hip joint isn't a feature here, we can direct our thoughts elsewhere to more specific things, and at that point maybe do some other types of blood tests. But I think just a random blanket screen of inflammatory markers, I'm often finding for any condition in the PZD is just not that massively helpful. Don't know what your guys' thoughts are as well. Thank you for listening, guys. I hope that was all right. I tried not to use too many Englishisms. I'm always laughing every Thursday when I hear you guys, because I don't know any of the drug names. I'm like, what is that? I'm looking stuff up and lots of other stuff that you say just tickles me a bit. So hopefully you followed me all right. And yeah.
Dave, that was a great talk. Thank you so much. So yeah, that was great. Very informative.
Thank you. Was there anything anyone wanted to ask or?
Yes, Dave, it's Erica Constantine here in Providence, Rhode Island. Thank you for a great talk. My question is, I actually got stuck at your case presentation because it was terrifying to me that this child was afebrile. Can you remind me what the exam was? Because for me, I have scanned quite a few hips and I have seen quite a bit of toxic synovitis, and that there is a minimal amount of children that I've actually tapped because I really think their physical exam, even if they're non-weight bearing because of their age, if I get good range of motion and they're not screaming when I move their hip, I kind of say, well, it's probably toxic synovitis. I do see an effusion there. I do the COCO criteria, check their ESR and their white count. And then, plus or minus consult ortho. So I'm curious as to what the exam was for this afebrile child that you had.
Yeah, I mean, really quite unimpressive. And I think not only was it much more junior members of the team who'd reviewed first of all and couldn't even differentiate hip, knee, kind of ankle. But yeah, not impressive at all. When I saw him, he was literally just stood on one leg. But he almost, you know what these kids are like. He was so young. They're almost doing some of this stuff behaviorally. I think someone could have easily sent him home at that stage and gone, oh, he's totally well, febrile, really, really happy, still eating, drinking, and he's got a clear upper respiratory tract infection. The truth be told, didn't in his case even look to be likely bacterial. You know, if we were applying any criteria for likely strep, he would have been really, really low. I know he went on to grow strep in his joint. So he looked like he might have just had a viral upper respiratory tract infection. His hips really did examine pretty fine. On initial review, he had full normal range of motion. I guess he was just evolving that day, that evening, into the following day when the ortho team admitted him, realized he was no better, and took a bit of a chance, if I'm totally honest, to going to theatre. I know he had high inflammatory markers, but they weren't certain. They were kind of, oh, you know, do we need to think more about osteomyelitis, and do we need to just get an MR and wait, or do we just go, you know, try and obtain some fluid? Obviously, they got the result that was the most obvious in the end, but I don't think it's always clear.
Yeah, because that's very terrifying to me, because I use my physical exam quite a bit to distinguish these toxic synovitis versus septic joints. I don't know what everybody else thinks, but that case is pretty scary to me, because I would have probably sent that kid home, even if I did see an effusion, because I would have thought probably a toxic synovitis, given how well this child looks.
Yeah, definitely. Me too. It was only because I guess the team had kind of mentioned bloods to Mum already when they arrived, and I was like, okay, well, we're sort of committed to it. I can't be 100%. The things that were making me a bit troubled, Erica, were the age, and I would definitely say that from the number I've done now, those, you know, under 1.5 make me prick my ears up a little bit more. There must be something in terms of movement with transient synovitis. There must be something to do with that capsular involvement in activity in a kid who's got a viral or environmental trigger. Just like I told you about the overuse kids get it a lot. I've seen loads of those recently. There must be something to do with that. So those who aren't as mobile, I always just think, oh, hold on a moment. And yeah, I think I too could have easily sent this kid home.
Erica, you brought up an excellent point. I think, you know, he would have come back is I guess how I'm thinking about it. Like, you know, we say come back if fever, come back if not moving again, despite NSAID. So my hope, I guess, is that he would have come back the next day, which is when he got tapped and all this stuff anyway, because, you know, he wasn't septic looking and this, that, and I don't think anyone would fault, and I would send home too, you know, like, I don't think there was anything, in the beginning, actually, that's also a sticking point about labs, right? So the child who I think has transient synovitis, no fever, can range, I'm not going to check the labs, you know, in a way, so that, because if I do get one number that's off or something, and then it's like, oh, look at this, why don't you want to do this, that about it? And then I could say, oh, he has 2 criteria, not 5, and whatever else. But I don't check labs in kids I think have transient synovitis.
I think that this is Lei from Yale, which is in Connecticut. I think this illustrates one of the challenges is that, you know, often the more we do, right? If you caught an effusion on ultrasound and there's a bad outcome, and I think you're sort of stuck. And I think I really worry about I put in the chat, the positive predictive value of a positive COCO criteria with an effusion for septic arthritis is still low. You need to tap like 20 or 30, I don't know the exact numbers, but you need to tap quite a few kids to find that one that has septic arthritis. And it's probably even higher in places like Rhode Island or Connecticut. We have this crazy organism called Borrelia that you may not have in England that causes arthritis in children. So I really think, that we don't have enough data to really go about it. If I see a child with a hip effusion, I don't know what to do. Physical exam, as we know, is unreliable for a child less than 2 years of age, and labs are very sensitive but not specific, that you still end up with a lot of false positives that you end up tapping, which again, I guess that's what we're stuck with.
Definitely, yeah. No, I think you're so right. Yeah, it's you'd really think there'd be some features that we could utilize that into a clinical decision rule, looking at appearances to help us a bit more. And I honestly, I was sort of looking at power Doppler and I thought, oh, this makes perfect sense. And then I looked at the literature and just nothing was there. So yeah, I think not so sure, other than the clinical decision rule I mentioned, how we can get beyond that. If we can save our kids who remain well being followed up, I think that's one little plus of the well ones, not requiring any follow-up. But it's for the ones who are a little bit more borderline, borderline on age or little temperatures, that sort of thing. I think it's a tricky one. Be interested to hear other people's views. Henry, are you there now? Can you?
Oh, yeah.
Oh, grand.
Nothing for that. I mean, it's very interesting. One of the things is I'm going to try, like, as I told you, we're doing a study here with hips. Haven't really tried a Doppler, so one of the things I'm going to try and see if I see a difference. But yeah, I have never seen that, or even I tried. I don't know if anyone else in the group has tried using Doppler.
Yeah.
You sound really far away, Henry.
No, I don't know. Sorry, is that better?
Did anyone else have any other questions they wanted to ask?
I have a quick one. You mentioned a 6,000 word dissertation on ultrasound physics. What is your training? What does your training look like over there? Really quickly, I know we only have like a minute, but what's the training for POCUS over there?
Yeah, that's a great question. It's extremely variable. So we're probably, I'm sure, like a lot of things in life, we're a little bit behind you guys. But especially in pediatrics, we're really just trailblazing this. And we did someone was mentioning PEPEC earlier. For those who don't know PEPEC, it's the Peds Emergency Research Council in the UK. One of my colleagues who does a lot of POCUS with me, he sits as the deputy chair. They did a bit of a mini Delphi looking at what people were doing. And again, to be honest, we were sort of doing as much, if not more than everyone else UK wide, including some really, really big centers. So our training was we did a sort of level 1 course, kind of 3-4 day course, and then we decided to do a postgraduate degree, which literally includes all of the stuff no one wants to get involved with, the physics and we actually did a systematic review. I did EFAST. So it's quite kind of big, meaty academic stuff, really, less about scanning, but with lots of training alongside. So we did it in our own time, and we were just scanning as much ad hoc as well as having focused teachings from people around the world. But no, there's an answer to your question, very long-winded answer, Erica. There's nothing specific or streamlined that people have to do. The emergency medicine doctors have to do the level 1 course, but the PEM trainees, which is obviously a really small subspecialty, don't have to do anything. Now, luckily, people have just seem to be loving this in my department. We've got a couple of the incoming PEM trainees from both the emergency medicine side and the pediatric side are super duper keen. You get the anaesthetists come down who are now really getting everything embedded into their training. And like I said, I've even got a couple of orthopedic guys on board with the joint stuff. So nothing formal. We're just trying to do as much as we can to bring it forward. I'm just laughing at your comment. I'm laughing at your comment about Billy Elliot being the best film ever.
It is so good.
Yeah.
Dave, again, thank you so much. As you can see in the comments, everyone enjoyed the talk, so thank you so much, and hope to have you again in the future.
No problem. You're most welcome. Thank you.
Thanks again.
Thanks. Have a good afternoon, everyone. I'll speak to you guys soon.
Dave, I don't see your email on the P2 list. I may be missing it.
Yeah, I think it comes to my hospital one, so it's david.mccreary@NHS.
Look at our list. Just make sure I've got it in here. Is it, you mean the Henry's emails go to that, the PEPEC stuff?
Yes. Yeah.
That I do not have on. So that this is, so the actual, the little blurb that went out, to the P2 network. So like the Pete's point of care network, which is a different, there's a lot of people that are on both Henry's thing and that.
Okay.
We emailed to that list, but I don't see you on that one.
Who sent the email, Matthew? Do you remember the name of the?
The email would have come from a Gmail account that's P2 network.
Okay. One sec.
Like it's the one that's in the, it's p2network.research@gmail.gov.
Yeah.
Gmail.
So yeah, sorry, I've just got it. I've got it from you, and it was sent, as you say, Tuesday. I got it Tuesday midday, and this is the one just with the advertisement, like I described.
Yeah, so that one is the ad. The actual email that has the search. So if we sent to the P2 list itself.
Okay, I'm with you. Yeah, so that's how I've got it. Right, no problem. Well, I'm here on there. It's David.McCreary, and then it's, but I can give it to you now. Is that more helpful? And you can just take it down.
Let me.
I'm in that list, is what I'm saying. If that helps, I'll be receiving them.
In Henry's list. I can just pull it out of Henry's list, and then I will send you the actual, it's a more elaborate version of that ad that has info on sort of what we're looking for, and then it's got the actual link that'll be specific to you.
Okay, no problem. Yeah, that's fine.
I'll send that in just a few minutes.
Right, lovely. Okay, no problem. Thanks.
Right. And you can feel free to that ad, you can pass that along to any of your colleagues that you think would be meeting to the kind of criteria. Because the goal really is as many people as possible.
Okay, I mentioned it to Niall Mullen. He's deputy chair of Peruki. I don't know who you've been dealing with there, if you've dealt with anyone at Peruki before, but he's pretty involved with that, and he's my colleague who does the most scanning where we are. So yeah, I'll pass it on.
Yeah, we're happy to have it. I mean, we're happy to have it. We've got various people trying to link into, all the different networks to send it along. So you can send it to him. If he wants to send it to Peruki, like people just email that Gmail account and I'll send them the actual link.
Wonderful, no problem. Yeah, good. Look forward to hearing from you, Matthew.
Perfect. Thank you very much.
Take care. Bye-bye. Thanks. Bye-bye.